And I'm very happy to be doing this. I hear I'm the first one of the series, so I really appreciate this opportunity. And yes, I will be discussing spinal cord stimulation and the effect of it in terms of treating gait dysfunction, and especially some freezing of gait in advanced patients with Parkinson's disease. I am a second-year PhD student, so this is part of my PhD research. And at the moment, our only financial disclosures is with Parkinson, Southwestern Ontario. So if you can see on the first slide here, I just have a little snippet of what we're going to discuss in my presentation. You can see here in the before video, this is one patient who was actually scooter bound. So he was pretty much 95% of the time in his scooter. This is our 20-foot carpet, which I will go into a little more detail. And this was him before surgery. And then this was him about 3 weeks after surgery with his spinal cord stimulator turned on. He didn't require any of us to walk with him. And I was just remarkable seeing this. So I'll just keep going. So these are the topics I'll kind of go through during the presentation. So what are axial motor symptoms and why do they appear? Current treatments for these symptoms and the successes and the failures. Why spinal cord stimulation could be a new therapeutic option for Parkinson patients. And then I'm going to head into the rationale of the study, the methods that I utilized, the results from this pilot study, and the conclusions from the study. As well as some of the research and some of the patient recruitment I've done since this pilot study, so in 2017, and then the acknowledgements. So first, we're going to focus on what are axial motor symptoms and why they appear. They do dominate after 10 to 15 years from diagnosis. Some of the features of axial motor symptoms are gait impairment, so shuffling of gaits. There are, people with history of falling, freezing of gait, so it's that inability to take a step. It kind of feels like your feet are glued to the floor, so that would fall into the gait impairment category. Postural instability, so spontaneous falling, we see that in advanced stage, as well as if I pull you back, and the inability to kind of break your fall, that would be considered postural instability. Postural abnormalities, so flexion forward, kind of like this bent posture, you're kind of bending forward at the hips, at the neck, cervical level. We do see speech, so stuttering, dysarthria, kind of slurring of words. Most commonly is low volume. This falls under the axial motor symptom category. And then dysphagia, which is a type of speech disorder that's seen in Parkinson's. These axial symptoms, they do produce a significant impairment. They reduce mobility. Patients have a loss of independence, so there is this dependence on your spouse or caregivers or friends or family. And then injuries, so because you're freezing or you're shuffling and then not being able to break your falls are one of the big things that can lead you to hospital time and long recovery times. So why do these axial motor symptoms appear? Well, it's thought to occur because of degeneration, so loss of non-dopaminergic pathways. We understand that in early Parkinson, we see loss of dopaminergic neurons, and this means that the lack of dopamine input in deep areas of the brain called the basal ganglia. And there's one little nuclei there in the brain. It's called the substantia nigra, and it's very, very, very small. And that has a lot of projection, so a lot of neurons come out of that nuclei, and they bind to another area in the basal ganglia, and these projections, they rely on dopamine. So when one area of the brain doesn't have dopamine, there's always this cascading effect, and that cascading effect we see in Parkinson's, and that phenotypically, so what do we see is reduce gait. So smaller steps, slower strides. We do see tremor, um, rigidity, so muscle tone, increased muscle tone, and slowness of voluntary movement. In the early Parkinson stage, and this type of phenotype, generally dopamine can help a lot. It can help increase step length and can improve step or stride velocity. But as the disease progresses, given about a decade or so, there tends to be a progressive loss of non-dopaminergic pathways. So these are pathways that aren't regulated by dopamine, but there are different neurochemicals in your brain. So you've maybe heard of serotonin, but the one that we believe that could be causing these postural and gait disturbances, and I've kind of outlined it here, is this neurochemical called acetylcholine. And these are areas of the brain that use acetylcholine. And because of the lack of acetylcholine input into these areas, we believe, and there's been some data showing that that's what's causing these gait disturbances in Parkinson's. So there are drugs available, but these aren't selective to help these areas of the brain. So there are a lot of side effects that could occur, and the effectiveness of these oral medications are just not there. So we are met with a huge unmet need for treating gait disturbances in Parkinson's. So what I will go through is our current treatment. All right, so right now in Parkinson's, we have basically two main ones. We have the use of oral medications, and we have the use of deep brain stimulation. The thing with treating postural and gait impairment in Parkinson's is that with time, these symptoms actually are resistant to dopaminergic therapy or to dopamine therapy. The most common one, the one used for over 40 years, is Levodopa. There is some research trying to understand why there's this resistance, and it could be because these gait disturbances are not due to dopamine loss, but it's due to maybe acetylcholine loss, as well as DBS, so deep brain stimulation, in a structure within the basal ganglia called the subthalamic nucleus. It can help very much. It's very effective for treating tremor and rigidity, and it can benefit people who are levodopa responsive, but there is a limited long-term benefit. So we know after chronic stimulation, these patients do require the need of levodopa, and we don't really see a good response in terms of their gait. And we have some studies here that we've shown that it could worsen their gait with time. Next slide. So this is just something about levodopa. Just wanted to say that it is the mainstay of symptomatic therapy for Parkinson's. As I said, it treats tremor, rigidity, and bradykinesia really well in the early stage, and it has associated with improved daily activities and better quality of life. However, with chronic use, so maybe over 2 years, maybe up after 5, 10 years, there is the introduction with motor fluctuations. What this means is that you take a levodopa dose, and then your symptoms aren't alleviated. You take another dose, and then it works. You take another dose, and then it doesn't work so well. So that's what motor fluctuations means. And then in terms of long-term use of levodopa, there's a side effect from it, and that's this creation of dyskinesias. And sometimes this dyskinesias is kind of like involuntary or squirmy kind of movements. That these dyskinesias can actually be more bothersome than the actual symptoms of Parkinson's. Here's a list on the side here that's showing features of Parkinson's that actually aren't adequately controlled by levodopa. And the main one up here is gait dysfunction, falling, freezing gait, postural instability. There are a numerous amount of non-motor symptoms that may not be treated as effectively with levodopa. So we're primarily going to focus on gait here. But you can tell that, levodopa isn't the perfect drug. This is one study, done in 2016, so a couple of years ago, by a group from Germany, and they found that using deep brain stimulation for treatment of gait, they showed that after about 6 months, it really improved their overall motor scores. So they did see an improvement in their symptoms. But with time, it tends to worsen after 2, 3, 4 years. As well as their freezing did help initially with the first year, but that tends to increase back up after 2, 3 years. So there is this really huge, significant unmet need for treating gait dysfunction in Parkinson's. So why can spinal cord stim be a new therapeutic option for patients? Well, one thing to note is that with DBS, or deep brain stimulation, only a fraction of patients are actually eligible for this intervention, and mostly because it's highly invasive. It is brain surgery, and also there could be some cognitive impairments with overstimulation chronically. So that's why we're looking at spinal cord stim, because it's a relatively minimally invasive procedure. It's only about an hour to an hour and a half, and we can do it in a wider population of patients, not just 1 or 2% of the population. Spinal cord stim is a well-established therapy, and it's used actually to treat pain, like failed back syndrome or chronic neuropathic leg and lower back pain. There are actual clinics in the U.S. that's all they do. They do about 40, 50 cases a day. But this treatment, in terms of for Parkinson's, came about on accident, where there is some pain that patients with Parkinson's do experience. And so that pain was treated with spinal cord stim. And then they found that after their pain was alleviated with the spinal cord stimulator, they also noticed improvement in their Parkinson's symptoms. So with about 28 studies, human case studies, have been done worldwide, and they've included patients with or without pain. They've noticed that they've tested a wide range of parameters, and within the wide range of parameters, there was improvements in their Parkinson's symptoms, but everything was subjectively done. So they used clinical scales or a physical examination, like UPDRS, which is commonly used, but unfortunately with UPDRS, it's not sensitive enough to understand, what aspects of gait are actually being improved. The scale itself, it has one area for gait. It's just called gait, and you rate it 1 to 4. And what it is you have the patient walk 20 feet away from you, turn around and come back, and you rate it 1 to 4. It's highly subjective, and it's quite variable between assessors. So these studies, they lacked the ability to understand, what parts of gait actually improved in these patients. So that's one thing that we'll be touching on in the project here. This was a review that was done in 2016, and it showed these are the different case studies, these different authors in different years, so all done just after 2010. Only, 2 or 1 patients were done. This was Tokyo study. They did 15. That was the most that's been done. Basically, why these people underwent spinal cord stim was for pain. These were the regions that worked the most, so it was kind of mid-thoracic level. And these are the kind of stimulation parameters that were used, and these are the improvements that they found. And they found that there were improvements after 1 year, 2 years, some were unchanged. And so there wasn't really, it was kind of hard for us to understand, which parameters worked the best. So what I did is we kind of formulated a table, this frequency with this pulse width produced this effect. We'll target thoracically, because if you go a little higher, it seemed to not work at all. If you went too low, it didn't seem to work too well either. So that's how my project was formulated. This is a recent study as well from 2016 from a Brazilian group, and they found they chose I think it was 4 patients who already went through deep brain stimulation surgery, and they still had significant gait dysfunction. This is after 7 years of deep brain stimulation. They were then given spinal cord stimulation, and after 1 month, they found that their gait was improved. So their overall Parkinson scores were improved. Their stride lengths improved after 6 months. Their walk test, so how long it took them to walk 20 meters, the amount of steps they took was reduced. So the more steps you take is an indication of shuffling, right? The more steps you take also indicates that you have smaller step lengths, which is more of a pathology of Parkinson's. So this study showed that even after 6 months of using spinal cord stim, there was about a 38% improvement in their symptoms. So what was our study? So we wanted to explore which settings and optimal settings would be used to treat gait using objective measures, so not using scales primarily. And we focused on looking at this in advanced Parkinson patients with significant gait problems, and they also had freezing of gait. We also wanted to select patients without pain because we didn't want pain to be a confounder in terms of if their pain was better, maybe that's why their gait was improved. So we wanted to select patients without pain. I'll also go through the methods here. So what we do, we have this carpet in our lab. This was actually in a video from the old lab center, but we have 2 carpets now. We have one that's 4 feet wide, and then we have one that's 2 feet wide. Essentially the 4 foot wide one, we're able to do some turning on there, which is great. You can tell here that this is one of our first patients in the spinal cord stim study. You can tell from his footfalls here that he was freezing here, freezing here, freezing right here, freezing here. So there's 3 types of freezers. You can have freezing, when you want to start walking, called initiation freezing. You have freezing while walking, which is shown here. You have freezing while turning, which is usually the most significant type of freezing. This gait carpet allows me to extract all different types of gait parameters. So from stride velocity, which is shown in this real-time graph here, to foot pressure changes. So right here, if I just pause it, this is kind of an aspect of freezing. There isn't this alternation of, your right foot, then your left foot is on, your right foot's off, then your left foot's off, your right foot's off. When both feet are on and it's kind of this kind of switching between the 2 feet, this is a marker for freezing of gait. And that's what we use to kind of automate number of freezing and the duration of the freezing. And we have an engineer in our lab who was able to come up with an algorithm to identify freezing episodes based off this data that we collected from our gait carpet. So everything is objectively done. We didn't rely on the camera to figure out number of freezing or how long a step length is. So we have a lot more detail in terms of what's happening with the gait in these Parkinson patients. These are some variables in terms of gait that we study, which we know are affected in Parkinson's disease. So spatiotemporal, space just is like distance, and temporal is time, so distance and time put together. So we have, step lengths. We would like to see them increase in Parkinson's. Stride width, so it's like how wide is your stance. So the wider your stance is an indication of how off balance you may feel. So if you think about a model's stance are very, very narrow, indicating good balance. Stride velocity, so how long does it take to go from left foot on, right foot on, to left foot back on? That would be stride velocity. And that's over a period of distance over time. Variability, so basically we look at So if you're walking fast, then walking slow, walking fast, walking slow. That would be high variability. Usually patients do have high variability in their gait, and that can cause falls. So if you're walking slow, then walking fast, then walking slow, this variability does induce falls. Step time, how long it takes per step. So from left foot on, right foot comes on, left foot comes off. That would be one step. And then stance and swing time. So how long your foot is in stance, so standing, and how long is it swinging, so when your foot is off from the floor. And then single and double support times. So that just means when you have double support, it's like how much time within one gait cycle are both your feet on the floor, and how long within a gait cycle is one foot on. And then asymmetry. So that's pretty common in Parkinson's because it's very asymmetrical at the beginning, but we know, maybe your left side has a shorter step length than your right, or you lead more with your right. So there's this asymmetry between values between your left side and your right side. So we're able to highlight this using our gait carpet. These are the tasks that I've used in the study. So we've looked at bradykinesia, so how slow voluntary movement is in the upper arm. We've looked at how fast one can go from sit to stand. So the faster you are able to do this, the less bradykinesia the patient is experiencing. And then what I will be focusing on is the ambulatory walking. So what I have is just the patients freely walk at their normal speed across the carpet. And what I mentioned in the previous slide, looking at these spatial temporal parameters, I do look at their body bradykinesia. We did identify freezing of gait episodes, and this is going to be another paper, but we're going to be looking at turning. So number of steps it took to turn and how long it takes them to turn. Balance, we did collect this data, but it's pretty hard to analyze this currently, so that's on hold. And we did do some speech analysis, and that's currently being investigated by one of their speech researchers. So in the pilot study, we had 5 patients, just like what Caitlin mentioned. The mean age of these patients were 71 years of age with a standard deviation of 10 years. These patients experienced Parkinson's for, on average, 14 years, plus minus 4 years. So before surgery, I had to collect some baseline data. So I had each of the patients walk across the carpet twice at their own speed while they were optimized on their current medication. And the medication would be Levodopa. Then they underwent spinal cord stimulation implantation, only about an hour and a half. We targeted the mid-thoracic level. And when you target this level and when you switch on the stimulator, what you actually feel, it's called paresthesia. So if you think of a numbness or kind of a tingling sensation, so that's what these patients were feeling. And the way that I programmed it was for this paresthesia, or this tingling sensation, to completely cover their both legs from the waist all the way down to their feet, from the front of their legs to the back of their legs, so their whole thighs, their whole shins, and I really wanted to get the toes and the soles of their feet. Then we used a Boston Scientific it's a commercially available medical device. The leads that were implanted, there's 2 leads in the middle of the spinal cord. So if I go back right here, so like in the middle of the spinal cord, middle of the spinal cord, and the 2 leads are right here along the midline. And what it does, it stimulates basically sensory fibers coming from your muscles all the way up the spinal cord to the cortex, so up to the brain. And within each of these leads, there are 8 contacts. So 8 contacts per lead, about 16 contacts in total. And these are the parameters that you can adjust for spinal cord stimulation. So pulse width, so it's like how long each pulse lasts for, and it's in microseconds, so it's in very, very small units. So we chose 200, 300, 400, and 500. The frequency, so how often this pulse comes, is it 30 hertz, 60 hertz, or 130 hertz? The current, so basically like how strong is the current? Do the patients feel it? How strong do they feel it? And what I did is basically there's a threshold, so when you just feel the stimulation, and then I went about 5% higher than that. And this was discussed in a previously published paper. So we pretty much kind of copied those parameters, and then I chose parameters that seemed to work well that was published in previous papers. So that's how we came about the programs to test. And what the programs are, they're a combination of these. So there were a total of 13 or 14. I think 500 and 130 together. The device did not allow me. So 1 to 4 months after surgery, I tested these different combinations, and patients came in once every couple of weeks, and we tested 1 or 2 settings depending on how fatigued the patients do feel. And from these settings, we were able to figure out which combination was best per patient. So what I did, I really wanted to tailor this treatment to each patient's symptoms, because yes, we chose, a strict criteria of patients, but even within that criteria, each person is slightly different in terms of their gait. So what I mentioned at the very beginning, one patient was scooter bound, so he could barely take a few steps at a time. Whereas with our first patient, he was able to take steps, but he had a lot of freezing in between. So already there was this discrepancy between the phenotypes of these patients. So each setting, their best setting was established per patient. I then had these patients use their setting over the course of this time, up until 6 months, and then I reassessed them while on medication. And these are some of the results I'll go through. So first we'll go through some videos, and then I'll show you the actual plotted data. So this is our first patient. This is Footfalls from our gait carpet. If you bring your attention to the top here, you'll see that before surgery, he was able to take steps, but they are small. The step length is very small. And you can see here, there's freezing episodes. So the red lines is the change in pressure, and the green line is the estimated center of mass. So you can tell that when he's freezing, the red lines just keep going backwards and forwards between the 2 feet, because essentially the next step wasn't able to continue. After surgery, I programmed him to a pulse width of 400 microseconds and a frequency of 60. And after I program that in, you wait about an hour to allow that program to stabilize like a clinical motor response. This 1 hour is arbitrary, but it was based off deep brain stimulation studies where they do wait on average about an hour before they test that setting. And you can tell right off the bat how his step lengths were significantly increased. The speed going across the 20-foot carpet was a dramatic improvement, and you can tell that he wasn't freezing. And everything else stayed the same. His medication stayed the same at this point. You can tell that at a different setting, so a little lower pulse width at 200, but the same frequency at 60, he had freezing coming onto the carpet. Yes, his step lengths were much better than before surgery, but you can tell that they are a bit smaller than the one that was his best setting up here. So just right off the bat, this was just an hour turning it on. It's an immediate effect that we noticed. 6 months after surgery, so he's been using this one really good setting for 6 months. I brought the patient back in, and This is before surgery. We have a comparative. This was 6 months after surgery, but I had him withhold his levodopa overnight. So it's kind of like a levodopa challenge. You're off for 12 hours. I assess you off your medication, and you can tell even off. Sorry. Okay. So this is the study where he was on his medication, but I switched off his spinal cord stim device. Sorry about that. And even with his spinal cord stim device switched off, his gait was still remarkably improved. So there seems to be like that plasticity effect, like a permanent change that's been introduced by the spinal cord stimulator. Then when I switched on his spinal cord stim device, it was pretty much similar between the two. So by 6 months' time, there wasn't much of a difference in terms of his gait, whether his device was on or off. So it really led us to understand, what was the spinal cord stim doing? Why would we see these residual, long-lasting effects of the effective spinal cord stim? So that's our first patient. The second patient here, this is the patient who was scooter bound. This was his footfalls before surgery. You can tell his footfalls are very, very small. It took about 5 minutes to walk the 20 feet. This was after surgery, and you can tell his 300 microseconds, 30 hertz was his parameter settings, so slightly different from the first patient. He had much larger steps. He felt much more on balance, and he was able to walk this carpet in definitely less than 5 minutes. This was on his worst setting, so it was at a higher pulse width, 500, and a slightly higher frequency. This was his worst. You can tell he had a lot of freezing. His step lengths were smaller, more variability in his step lengths, and the yellowed out parts is just his canes. So we don't include that in analysis. So right away, an immediate effect upon turning on the device in the lab. When it came to 6 months' time, so the top part is just before surgery. Here is 6 months after, where I had his device switched off for a couple of days before. Still, you see the same improvement. It seems to be a permanent change in terms of his gait. And then when I switched on the device, I still was able to see a similar improvement whether his device was on or off. So these are just showing kind of in a plotted manner in terms of frequency. So we tested frequency, and then we tested pulse width. So each colored lines is a different pulse width. And then for example, right here, this is 400 pulse width with 60 hertz. On the left here, it's a mean Z-score. So what I did is all the gait parameters that we were expecting to increase. So for example, step length, we want to increase. Stride velocity, we would like to increase. Single support time, we would like to increase. We would group those together, and we would calculate a change in terms of from baseline to his best setting. And we found on average, this 400 pulse width with 60 provided the most improvement in terms of those parameters of gait. When we grouped parameters that we expect to decrease, such as double support time, step time is another one, gait cycle time, stride width. These are parameters of gait that we expect to decrease. I grouped the changes in terms of from baseline to when I tested that setting. We also found that 400 pulse width and 60 frequency was the best. If you can see here, so a pulse width of 200 and 60 hertz provided the worst improvement. Whereas with 260, once again, it didn't improve his gait in terms of the parameters that we expected to decrease and the parameters that I expected to increase. So for one supposed to increase, you have to have a positive z-score. For parameters you expect to decrease, you would want to see a negative. So it's going down. So that's patient 1. For patient 5, we also showed that he also liked 400 pulse width and 60. We showed a similar effect here. One thing to note is that even though these two patients found the same program provide the best motor improvement for them, there was no trending in terms of, okay, 200 pulse width for him, 260 was actually, it wasn't too bad, but for this patient was worse. So there was no trend in terms of as you increase frequency or as you increase pulse width, you'll see an improvement in these scores or a decrease. So each person was a bit different. These are for the other two patients. I wanted to note that for this patient, a high frequency and a 300 pulse width provided the best effect. Whereas for this patient, 300 pulse width with 30 or 130 provided a good effect in terms of the gait. So once again, everything is unique. There was unique changes to gait due to different spinal cord stim combinations for each patient. So during the study, not only did we do a gait analysis over the carpet, I also completed scales with these patients. So one main scale that I did at each visit, it's called the ABC, or Activities and Balance Confidence Scale. So it's how confident you are in doing a task. And the scale goes through, I think it's about 20 or 25 scenarios, such as walking around your house. And I ask, how confident are you in not falling when you walk around the house? And the patient will go, 100%. I feel pretty confident. Or, 20%. I usually fall. Like, I'm not very confident. So at the beginning of the study, before surgery, patients were on average about 40% confident in doing tasks around the house and outside the house. By about 6 weeks after surgery, we found that there was a significant improvement in terms of their confidence in doing these tasks, so about a 20% jump. By the end of the study, it plateaued at about 60-70%, which is a significant improvement from baseline. We did find that after 16 weeks of using the device, that there was improvement in their UPDRS score. So that is the Unified Parkinson Disease Rating Scale. So it's an overall score of their different symptoms. So tremor, bradykinesia, rigidity, those are the main ones, but also we go through postural instability. There's the gait score in there. So when you sum those scores per person and then average them across 5, there was a significant improvement in terms of their overall symptoms of Parkinson's at 16 weeks and continued at week 24. I do 2 other scales that did not significantly change. The one in purple here is called the Parkinson's Disease Questionnaire. There's 8 questions. It's more about do you experience muscle spasms? Is there attention deficits? So it was kind of unrelated to unrelated to the gait symptoms. And then the freezing of gait questionnaire, which is in green, there wasn't a significant change. And that wasn't because freezing of gait didn't improve. We obviously saw that there was improvement in their freezing, but this questionnaire, it focuses on duration. So there's about 6 or 7 of the 10 questions that focus on duration of freezing, and there's just 1 question that focuses on how often, so number of freezing episodes. And what we did find, and I'll show you in 3 slides as to why we saw differences. So we'll get back to that. This is just showing the key gait variables that improved over the 6 months. So this is pre-surgery. Blue is step length. Red is stride velocity. Swing percent, so like how often is the foot in swing mode during a gait cycle. Purple is single support, and teal is double support. And this was on average between the 5 patients. The bars are standard deviation bars, so variability between those 5 patients. This is before surgery, so there's no spinal cord stim, but they're on medication. This was tested on their best setting per patient. I took those values from their best setting and grouped them together. And then this was when I retested their best setting 6 months after, without the stimulator on, and then with the stimulator on. Because of the low sample size, we just saw significance in stride velocity. So there was improvement when I switched on the device in the lab. And then there was improvement at the 6-month point when the device was switched on as well. I mean, you can tell that this one is larger than this one, but there was no statistical significant difference between the two. We did see step length improve, it did improve here. It's higher than baseline, and it was still higher than baseline. Just so you know, on average, for patients within their age category, so about 60 to 80 years of age, the average step length for those patients without Parkinson's is 60, as in centimeters, so 60 centimeters. So patients with Parkinson's with significant gait dysfunction was about 20 to 30, so it's about 50% lower. And then by the time they were using their device after 6 months, we raised it to about 40, so that's about 25% improvement. Their stride velocity significantly improved, so it went from about less than 60 to about 55 centimeters per second. On average, patients without Parkinson's, their stride velocity is about 110 centimeters per second. So you can tell it's about 50% reduced. When with the device switched on, it does improve their gait, but it's not all the way to control levels. I have published this results in a really good journal recently in the last month. And what I did in the discussion is that I found a paper from a group from University of Waterloo that showed that Parkinson patients without gait dysfunction, their stride velocity is about 85 centimeters per second. So what we were able to do in this study is that the spinal cord stimulator device was able to improve the stride velocity to a level at which patients without gait dysfunction are at. So it's a really terrific improvement that we're able to do with this spinal cord stim device. These are 2 graphs about asymmetry. So what I told you about differences between left and right side. What you want to see is you want to see a decrease. You want to see a low percent in asymmetry. So 0 would be both sides are symmetrical. You can tell before surgery, step lengths and step times are very much different. But then after using the device, there's a trending that they are reduced. Same thing with variability. You want to see low variability. So before surgery, it was higher than 20. And then after surgery, we can reduce those values much lower to about 10. What I did find with variability with the spinal cord stim device on is that it didn't improve the spinal cord stim device as much. You can tell with this value here. But when I switched it off, it tends to reduce the variability. So not too sure why we're seeing that, but that's something that I've observed. So back to freezing of gait. So like I mentioned earlier, we can measure or automatically measure number of freezing episodes, which is in blue, and how long each freezing episode happens in red on our carpet. And we found that before surgery, patients were freezing on the carpet 10 to 20 times. One patient froze, more than 30 times. And how long is each freezing episode on average? About 5 to 10 seconds. What I did find is when you switched on the device in the lab, the number of freezing episodes dramatically went down, and the time that they were freezing was dramatically reduced. After 6 months of surgery, there was still a little bit of freezing with the device switched off, But when the device was switched on, there was no freezing on average. I think I think one person froze while the device was switched on. And what I didn't find was significantly different was the duration, so how long each freezing episode occurred. So what we found was the frequency of freezing was dramatically reduced, but when you do have a freezing episode, you may freeze for a similar amount of time as you did before receiving this surgery. So that was something that we found interesting. Um, so just some quick conclusions from that pilot study. We showed that all participants improved in their gait and they had reduction in the number of freezing episodes. We found pulse widths of 300 and 400 combined with the frequencies stated here provided the best effect for these patients. Stride velocity increased by 54%. Step length increased by 57% on average. In the lab, on average, the number of freezing episodes reduced from 16 to 0. Confidence in doing daily activities increased by 71%. That's huge for patients who have significant loss of their ability to do things around the house. The most interesting thing that we found was that these patients are on levodopa for a chronic amount of time, over 7 years, 7 to 10 years, and they're on a high amount, about 1,200 milligrams on average. So, taking that 5 times a day, but total of 1,200 milligrams per day. What we did find is that with the use of spinal cord stim, we had to reduce the levodopa dose, the daily levodopa dose. And that had to be done for 3 of the 5 patients. And that was because these patients were experiencing dyskinesias. So they found that with the spinal cord stim device on and with their levodopa dose unchanged, they were experiencing dyskinesia, mostly in the lower limbs. One patient was having it more in the upper body. But when we reduced the levodopa and kept the stimulation intensity the same, their dyskinesias were reduced. So at least that was taken care of. This titration of levodopa is similar to what's done in deep brain stimulation, and that's one of the main reasons why DBS is done, is because these patients could be on 20 pills a day. So the ability to have surgery and take maybe 50% less, or even be titrated completely off levodopa for a year, that's a huge improvement in the patient's quality of life. But we were able to do this through a minimally invasive surgery while also improving their gait. What I want to just briefly talk about is what I've been doing the last 6 months or so. So we are looking for about 15 more Parkinson patients that I hope to do this year. It is ambitious, but I think we have a really large population of patients in the area here that Dr. Jog sees every week. So far, there's 4 that I'll be looking into doing this year, and this is only January. Since last year, there's been 7 patients that we've implanted, 5 of them with Parkinson's disease, so 3 were male, 2 were female. Mean age is 72, so very similar to our pilot study. And duration of disease is about 15 years, so once again, similar to the pilot study. What we did do, we did a couple case study patients with cortical basal degeneration. Just a little information about that. This is a very, very progressive disease where gait dysfunction, where you're going from walking, few miles a day to wheelchair bound in about a year. The life expectancy for CBD is, I think, on average 7, and that's just because of the lack of independence, and it's just very, very fast progression. So what we had 2 patients with this syndrome who had the disease for 2.5 years. Both patients are wheelchair bound, completely dependent upon people to get them to transfer to do, washroom or going to bed. What I did find with both these patients is that they're able to transfer much easily. Their posture has improved dramatically. One patient, because it's asymmetrical disease as well, she has the inability to, she was dragging her foot, like her toe, when she would walk. So she was able to take very small steps, but her right foot would drag. After using spinal cord stim, she's not dragging that foot anymore. So it's a really incredible to see that. So she's now walking 20 feet with the walker at home with physio every day. And so that's been a really success story for CBD patients. For Parkinson patients, we've seen similar improvements, like I've mentioned in the pilot results. Unfortunately, there were 2 withdrawals with these 7 patients. One, he contracted pneumonia. This is unrelated to the use of spinal cord stim, and because of contracting that, he eventually passed away. And then another patient I had to withdraw because she had her sciatic pain returned. And so what I've heard from her, though, and I think I'll bring her back to do a little assessment, is that her freezing has gone away. So that's been a really big success story for her. The other thing that I've started doing is I've done a slight change in the protocol. So now I'm trying to assess, what's levodopa, what's happening with levodopa. Why do we need to reduce levodopa in some patients? So I'm trying to assess the effects of when levodopa is not in the body, and then when patients are on levodopa, and seeing how their mobility changes before surgery. I'm also assessing them at 3 months, at 6 months, and then at 12 months after surgery, while off and on the levodopa, and then I can monitor how their mobility changes while on these different medication states. I've also cut out 500 microseconds in terms of the programs that I'm using, because I found that was the worst one. So I've cut that out, and I test these programs in a repeated measure just after surgery, so 2 to 4 weeks after surgery. In the pilot study, I extended that up to 4 months, and what we realized is that there were improvements that were happening at 4 months versus 1 month because of these plasticity changes. So now I've really confined it in a more controlled manner, so it's going to be a bit better study. And a new objective now is not only looking at how their gait has improved, but also exploring the effects of spinal cord stim in terms of brain activity. So what changes in cortical excitability are we seeing? We understand in Parkinson's that there is abnormalities in these areas. And there's one way of measuring this is not using MRIs or functional MRIs. They will not allow me to understand which areas or what neurochemicals are changing in terms of their activity, but I am using a technique called transcranial magnetic stimulation. And here's a schematic of a person with a coil. So what it is, it's a coil kind of held on top of the cortex, primarily the motor cortex. And what it does, it produces a magnetic field. That magnetic field produces a current that then stimulates neurons in the cortex. The cortex, those cells or those neurons in the cortex, those are the neurons that go all the way down through your brainstem into your spinal cord, down, down, down into the spinal cord, into your arm, same nerves. They connect all together, first order, second order nerves, all the way down to the muscle. When you stimulate using a magnetic field, it's not painful. I think in the 80s they used electrical, and that was quite painful, so we stopped doing that. So when you do a little stimulation up here using the magnetic field, it produces a muscle activity in the hand, and that's an objective measure. So we're able to measure different pathways and the activity of those pathways and how those pathways may change when these patients undergo spinal cord stim. And that's something that I've learned over the last couple of years, and I hope to continue doing that with the help of Parkinson Society Southwestern Ontario. I hope I didn't go too fast for everyone, and I would love to hear some questions. I really enjoyed talking to you guys, and I really would love to hear some feedback. So just quick acknowledgements. Our patients spend a lot of time and traveling coming here to London, so I'd like to thank very much for the patients' time and all their help and input. This would not be doable or feasible without Dr. Mandar Jog. That's his picture right there. And then the surgery, so this would not be able to be done without Dr. Parent. He's the chief of neurosurgery here at University Hospital, and we designed this study at the end of 2015. So we've done all this in a couple years, so it's been really successful. Bozy, Lena, they were two researchers in the lab. One was a fourth-year student who helped me out a lot during 2016, and Bozy really helped me a lot collecting some of the data and help doing some of the analysis. And Sarah, she's not with us anymore, but she was the engineer who came up with the automation of detecting freezing from our gait carpet. One other thing I'd like to mention is we have a next webinar. It's February the 21st, same time, 12 to 1 p.m., and it's going to be about vision and Parkinson's research. It's going to be by Dr. Elizabeth Irving, professor with the School of Optometry and Vision Science at the University of Waterloo. And I believe that's it. Thank